Mình unmute cảnh lên đi, unmute kênh anh Bình.
Okay. Good.
Yeah.
Okay.
Rồi mình record vô the cloud được anh Ninh ha.
Đúng
Rồi
rồi.
xong rồi download xuống thôi.
Đúng rồi.
Rồi. Okay, so hello everyone. This is another VietMD JC7 presentation. The Journal Club. We do every 2 times a month. So this Journal Club today, we will talk about the hormone therapy, replacement therapy for primary prevention of chronic conditions in post-menopausal women. This is a guideline given out by the U.S. Preventive Services Task Force, or USPSTF. They talk about the use of hormone therapy. You may know that more than 15 years ago, around early 2003, 2002, 2003, there's a huge study, the WHI study about this issue, and now I think they want to come back to review this. So today, Thi Dương, Tuấn Trần, and Hương Trần will help us review this study. So Thi Dương, go ahead.
Okay, hello everyone. My name is Dương. Welcome to the first Journal Club topic of April. And it is our great honor to welcome Dr. Hồ Quang Phú, Dr. Đinh Nguyễn as guest speakers, and Dr. Minh Đỗ as a consultant, and many other doctors and med students. Thank you for spending your special time attending this section. Today's topic of interest is prepared and presented by 3 members of the VietMD Journal Club. And let me introduce our team to you. My name is Dương, and there are Tuấn Trần and Dr. Hương Trần also in the team. We will take turns to present and discuss the U.S. Preventive Services Task Force recommendations regarding menopausal estrogen for the primary prevention of chronic conditions in postmenopausal women. As you all know, the time period after the complete cessation of the menstrual cycle in women can be very troublesome for many women, and hormone therapy is prescribed to ease many of the discomforts associated with menopause in those women. However, as we age, the risk of developing chronic diseases increase, and among many risk factors, the hormone levels in the body is long been proved to be an important and complicated risk factor. The U.S. Preventive Services Task Force, which focuses its work on preventive care, has published these guidelines to give recommendations to some of the most concerns associated with using hormone therapy for the primary prevention of chronic conditions in postmenopausal women. This guidelines based on a systematic review of the task force, including the largest trial on this issue, the Women Health Initiative trial. Our presentation will consist of 4 main parts. To begin with, I will give audience a brief review on the use of hormone replacement therapy and the introduction to the guideline of the task force. Then Tuấn move on to to inform you of the methods and results of the systematic review conducted by the task force that leads to its recommendations. And finally, Dr. Hương will raise some questions for further discussions and a clinical case discussion to find out how we will apply these results into legal decision making. So this is a Vietnamese version of the previous slide, which will help you to have a better understanding and a better catch with the presentation. So I will go through it in Vietnamese. Mục lục của bài trình bày sẽ gồm 4 phần chính. Đầu tiên sẽ là tổng quan về liệu pháp hormone ở phụ nữ sau mãn kinh và giới thiệu về guideline của the task force. Tiếp theo đó là Tuấn sẽ trình bày tiếp về phương pháp và kết quả của tổng quan hệ thống mà task force đã thực hiện và đưa đến các khuyến cáo của task force. Cuối cùng là chị Hương sẽ bàn luận về các tình huống trên lâm sàng. First and foremost, let's go through some statistics about menopause in the United States. So menopause is the complete cessation of the menstrual cycle in women, and it is often defined in retrospect 12 months after a final menstrual period. And 51 is the average age of menopause in the US. And with 6,000 US women reaching menopause each day, there would be 2 million US women who reach menopause every year. And there are 80% of women report no reduction in quality of life due to menopause. So that would mean 20% of them did suffer to some extent the discomforts associated with menopause. The effect of menopause on women can be classified into 4 main categories. The effect on the vasomotor system, which manifests as hot flashes, night sweats, and excessive sweats. The effect on the urogenital system, including vaginal dryness, soreness, and urinary frequency and urgency. The effect on bone metabolism, which makes women more susceptible to bone loss, osteoporosis development, and fractures relating to osteoporosis. The effect on the cardiac function will increase the vulnerability of the women of getting heart diseases. These effects of menopause are believed to be mainly due to the reduction in endogenous hormone levels, especially a decrease in the estrogen level in the body. So that leads to the idea of using hormone therapy to alleviate symptoms and effects associated with menopause. So what is the current evidence suggest? What does the current evidence suggest? Why there is high quality evidence supporting the use of short-term hormone therapy for menopausal symptom relief, such as for the relief of vasomotor and urogenital atrophy symptoms. The recommendation for or against the long-term hormone therapy for the primary prevention of chronic conditions is still needing more high quality and solid evidence to make a firm conclusion. We have data from observational study and animal studies suggest that estrogen have a cardioprotective effect. But high quality evidence, RCT, particularly the Women Health Initiative trial, which is considered the largest trial on this issue, prove otherwise. And now the Women Health Initiative trial was even stopped earlier due to the finding that there is an increased risk of stroke, coronary heart diseases, and venous thrombosis in the active treatment arms or in the patient group being treated with hormone therapy. So the So the the task force recognizes the need to conduct a systematic review on this issue to provide more solid evidence for the use of hormone hormone therapy for the primary prevention of chronic conditions in postmenopausal women. Now, Tuấn will continue to give you information regarding the method and results of the systematic review and the task force recommendations.
You người tắt share đi Dương.
Okay, I'm sorry.
Well, thank you for your vision, and now I'm continue to our presentation by talking about method and recommendation. The task force make the recommendation on use of hormone therapy for prevent chronic conditions in postmenopausal women based on 18 RCTs from the trustable sources such as Medline, Embase, Cochrane Library in the population of postmenopausal women who receive estrogen with or without progestin as a hormone therapy compared with placebo. The outcomes are decrease of any chronic conditions such as coronary heart disease, breast cancer, dementia, gallbladder disease, stroke, VTE, urinary incontinence, diabetes, fractures, or colorectal cancer. So the results were shown in two tables. With the left one is the comparison of estrogen and progestin with placebo. The other one is about the estrogen alone. In general, we found that the hormone therapy has some adverse effects that include CVD, VTE, stroke, and gallbladder disease. Besides these effects, hormone therapy results in a significant improvement to reduce risk of bone fractures and diabetes. Interestingly, the combination of estrogen and progestin increased the risk of breast cancer, while the alone estrogen did not. Even it decreased the risk of breast cancer. The results suggest the estrogen and progestin stimulates the breast cancer growth and delays breast cancer diagnosis according to WHI. So in the postmenopausal women with or without hysterectomy, we can see in these table that the hormone therapy all reduce the risk of diabetes and fractures. However, diabetes and fractures can be treated by their medications like metformin or bisphosphonates. So is there any chance to the hormone therapy for treatment or prevent their conditions while the women receiving them undergo many harm effects? So here is the task force recommendation. They say in the postmenopausal women, do not use combined estrogen and progestin for the primary prevention of conditions, chronic conditions. And in the postmenopausal women who has hysterectomy, they also say no to estrogen alone. To clarify their recommendation, they also say that their recommendation only apply for women who are considering hormone therapy for prevent the primary of for the primary prevention of chronic medical conditions, but it does not apply to the women who want to manage menopausal symptoms like night sweats or hot flushes. And the task force also arranged the grade D for both their recommendation. And so what is the grade D? So they explain that the grade is that so there is moderate or high certainty that the service has no net benefit or had the harms outweigh the benefits. So to conclusion, the task force recommendation say no to both the postmenopausal women with or without hysterectomy. So that's all about my presentation. To continue, Dr. Hương Tran will talk about the discussion and some clinical case.
Now, all of us have gone through the summarization of the guidelines from U.S. Preventive Service Task Force. So, as Tongchen said, this is a very controversial topic because, as you know, the hormone therapy may give some benefit over this disease, but it creates a lot of harm to many other diseases. So when we enter the next section on discussion, I'd like to raise some clinical situation in which the clinical decision may be difficult for us to decide whether we should consult the patient on the hormone therapy.
Yeah. Can you speak up a little bit?
Let me share my screen.
Can you speak up a little bit? Yeah. Yeah.
Okay. So, based on what we have already learned about the guidelines and the recommendations, so I'd like to discuss with you about a real application of the guideline in daily practice. So suppose a menopausal patient of yours, she insists on being prescribed hormone replacement therapy because maybe she heard from someone and she believes that it helps her to preserve the beauty and to look younger. So what should I do, or what should you do in such situation? So I'd like to invite some of you guys here to speak. So just to tell us your opinions, and then we will go from that, and we will have our consultant here to give us advice. So anyone volunteer? So let me clarify this. So if you face a patient who asks you about whether you can prescribe the hormone therapy for her, just to for her to feel better, to look younger without any symptoms. So what should you do in such situation?
Yeah, I don't know. Besides our consultant over here, how many of you actually practice and prescribe hormone therapy for the patients? But let me share a little bit of my personal experience about this. When I finished my thesis, it's in Vietnam in 1999. We did a survey for the symptoms and like social symptoms of menopausal conditions on women on this area. So I have a chance to went through some literature, and it's quite interesting. It's quite depends on the culture, the society, and seem like in Western society, there's some associations of youth and beauty with having period, based on the literature I read that time. So the hormonal therapy and try to prolong the hormone level in the body. People prefer that. Why in different society, stop having period is something people kind to celebrate about, and especially my mom, when she stopped having her period, she's so happy with that. So it's quite depends on the culture. At that time, there's a study, actually the WHI study, when Vietnam is one of the sites they collect information about hormonal use at that time. So there's talk about use of hormonal therapy based on the current knowledge. And at that time, we still believe that hormonal therapies provide benefit to the menopausal women. So we start talking about that more. We did not talk about hormonal replacement therapy in the past before that time. So we start talking about that more. And after a few years, when the WSI study came out, then everything go back to where it used to be. But then the story not end there. We have our consultant here, actually Dr. Bùi Chí Thương, and also from Australia, Dr. Quang Phu Ho will share with us more information about that. So if no one have any question, then Hương, what should you do? If someone approaching you and ask, I just want to feel happy, and I heard that or healthy or young, and I heard that hormonal therapies will prolong my beauty, what would you do?
Me? Yes, me.
Simon, what answer here?
I think that when I read on the internet about this topic, the beauty and the hormonal therapy, I see many articles on very well-known newspaper, both English and Vietnamese, and it's quite of interest. It's a topic of interest for everyone. And then I research the literature, and there's a certain of research which seems to prove some association between the skin aging, the skin health, and the hormonal therapy. So but it haven't come to the conclusion yet. So I think that in this case, if I see my patient, they tell me their concerns, and then I'd like to clarify for them that there's still not enough evidence to support the use of hormone to stay younger, to look more beautiful. But I will explain the risks associated with using hormone regarding to many chronic condition, as we have discussed before. And I also like to refer to some of the recommendation of other association or society in this topic. So in the screen, I just summarize some of the guidelines, the current guideline on the hormonal use, and the indication mostly is for the patient who has symptoms, who has menopausal symptoms like hot flashes, vulvar vagina dryness, in short term. So that patient will benefit from the hormonal therapy. Plus, the FDA also approved the use of hormone for osteoporotic for menopausal women who has high risk of osteoporotic fracture. So that's the to me it's the only indication for primary prevention to my knowledge. So and other association like the AHA or ACOG, they also advise against the use of hormone for cardiovascular disease prevention. And one of the important points I want to analyze here is they also say that the decision should be individualized to balance the benefits and the risk, which is very complex in some situations. So in the next slide, I also want to raise my concern about like what aspects or what factors that you should consider as the physician to when a patient comes to you and seek for the hormonal replacement therapy. So this is some of the factors that I found on the readings. So I also would like to hear the opinions from the consultant and other senior doctors here about this.
Yeah, okay. Yeah, just want to remind everybody our activities here is have several form of several reasons we do this activity here. One is to practice English, practice presentation for our team member here. That's the first thing. And along the way, we would like to create the habit of reading and updating information to the young upcoming doctor. It's a very good habit to get. So yes, that's why we have the expert here to help us dissecting the evidence and discuss about the current practice of what we are discussing. So let me invite Dr. Wang Fu Ho. Our special consultant over here is almost midnight in Australia, but Dr. Ho still with us today. So Dr. Ho, can you share with us your experience when the WSI came out, and also give some feedback about the presentation so far to Dr. To Yung Lương Tuấn Trần and Dr. Hương Trần so far. Dr. Wang Fu Ho.
Hello. Can you hear me? Okay. The first, presentation was done quite well. With introduction very clearly. I think the second part when Tuấn Tran presenting a bit confusing, and I wasn't clear. I'm sorry, I'm not criticizing him in a way, but I think if you present a paper like this for the audience, I think it'd be confusing and with lack of evidence and lack of, information to prove, to show us, I didn't follow what on the talk. And lastly, who just presenting, so she need to summarize, what the other two speakers have spoken and what evidence, because mainly today we discuss about the US preventative, task force to advise for the clinician how to use hormone replacement. So that's the most important task tonight, that you have to summarize so we can learn from the task force that what they have recommended to us clearly in terms of scientific and in terms of where they do to get information from. Even though you mentioned WHI, her study, but I did not hear all the, other chronic disease, like you mentioned about diabetes, you mentioned osteoporosis, breast cancer. The most thing has put off people from using HRT for so far. That's the most important, and the most media has portrayed HRT and is an evil. We're causing more 30% increasing in breast cancer. Even those we read the article, on the WHI, only 9 cases, extra cases per 10,000. But you're working in how to manipulate the figure, you can make like excellent headline for the for the article in the paper. So I like to go back a bit about what we come up with all these things. U.S. task force, mainly WHI is a landmark study which terminate it quite early, because after 4.52 years they want to go to 8 years. But they terminate prematurely because the risk of breast cancer. That's the main thing. They stop people from going further. And this study also very important study. We will use a post intervention study to follow up for many years afterward to see whether these the intervention help the patient or have increased in the risk of the disease on other people. So you have to mention thromboembolisms and gallbladder disease, cognitive problem, and Alzheimer's disease or colorectal, and many other things. But concentrate more on breast cancer is the one that fears most people put up with it, taking HRT. So HRT, WHI, I summarize in this way. I send you the summary of HRT before of WHI. Women in Health Initiative randomized control multi-center study. It's a multi-country study. And they got 2 arms. One arm, they use combined estrogen and progesterone. And the other arm, they use only progesterone only. For these 2 arms, the arm of estrogen and progesterone, we know the increase in risk of breast cancer, cardiovascular, CVA, and thromboembolism. And the arm with the estrogen alone is the decrease in the breast cancers, and that's the one of the main important. If you have to get it evidence to relate to the patient. On the task force, also look at her study. Her study one of very important study looking for the evidence. Her study had shown that increasing cardiovascular accident. So these 2 studies is the most thing you have to use. Now, why talking about in the context of us, in terms of clinician, we use it. In Australia, in America, in every other country, we got a college called College of Obstetrician Gynecologists. We base on them to give us an advice. The same thing like U.S. task force, the Australia American College ONG put out the statement to help us in terms of guide us to use whether it's safe to use the HRT or not. So I'll go back a bit about the HRT. What wrong with HRT? Why HRT important? Why you talking about keep a woman young, healthy, look better, look at skin better. Everyone before that at the medical school, we know that men die younger than women. And women usually healthier than men until they reach menopause stages. When they start, we're thinking that many years ago, I've been taught in medical school, if after menopause, the woman estrogen deplete, that's where all the problem, people start getting heart, more, the risk of cardiac disease increasing, osteoporosis go in, people get urogenital problem with, dryness, get incontinence, and people get hot flushy, they're terrible, night sweat, they could sleep, they got mood swing, they got irritable. That's most, all day we laugh at the woman in our teacher in the class when it's so moody after menopause, because they HRT, they lack of estrogen. So that from that basic scientific, we think, everyone before the 2003 up to WXI, we as a clinician, we put every woman after menopause on HRT. We know HRT help them in terms of, they alleviate all this problem. So HRT, actually after WXI come out, we know that we were wrong. Even though WXI had a lot of fault in that. They recruit the patient up to 73, 74 years of age. I forgot what rate. But it's too old. These people after 60, the risk of cardiovascular, everything increasing. At the menopause stage, menopause about 52 or 52.1 years of age. So 73, they sometimes recruit very late. Their artery already got, the plaque, arteriosclerosis, everything there. The risk quite high. But put it aside, from the study tonight, presentation tonight, I need more scientific to put in. You prove to me that this study, you get all information, this study, her study, WHI study, what important that conclusion from those studies to help the task force to come up with a conclusion. Just some simple slide and probably, defeat the purpose of the Journals Club study. Now, if you ask about in practical term, what we do, if the patient come ask for menopause, HRT, most people don't want HRT after all the scare from WHI. Most people will put up with it. But if they ask for HRT, what we advise at the moment, we use a lower dose as possible and use a shorter duration as possible, and we only use to treat their menopausal symptoms such as hot flushes and night sweat or mood swing. Other osteoporosis and other, osteoporosis is a long-term prevention. You have to take more than 10 years to get a benefit. So cardiovascular, we know the risk high, thromboembolism high, breast cancer definitely is high in terms of you using combined estrogen progesterone. So I would advise them use as short term as possible. I'll get them to come back after 6 months to review them and get if the symptom is improving, I wean them off slowly. At the same time, also if you go for exam, if they ask you this question, you have to advise the woman to take calcium, drink milk, exercise, and also if they lack vitamin D, we have to give them vitamin D to prevent the osteoporosis. Osteoporosis is an awful disease. About the youth, the health, the young, probably not true. It can only help them in the symptoms, but not help them in the long term. They might eliminate in terms of the urogenital problem, the vagina dryness, affect them with sexual relationship. We're going to give them the topical estrogen. There's some evidence that showing there might be increase in risk, but the risk is very low. So we can use again the low, show the benefit possible. Now, the message I like to convey to all the, the young aspiring doctor in the future, or the doctor really, everything we do these days will be based on scientific. And where the scientific comes from all the task force or college recommendation, we're not guessing. We have to use the evidence and prove to the patient, this is study done, randomized control, proven, all the scientific utensils had approved it, and we treat the patient. And based on this one, will be safe, and we're not liable to litigation later on. So that's for my talk. I think it's probably too long. This is very difficult. I text, a message Dr. Mendo early. It's quite difficult. If you don't understand WHI study, you can't talk about this one. With this one, they almost rely on WHI study and her study. So this is important. Go back, look at it, and don't have, when you're presenting, you will need more information. More you prove to me, you let me know that what information get from, and are we happy with it? But sometimes some few slides will not convince the audience. Thank you.
Okay, thank you, and Dr. Wang Fu Ho for the background of the landmark study WHI and then the HERS trials. We also have today Dr. Bùi Chí Thương from Vietnam. I don't know, I think Dr. Thương was in his residency training by the time of the WHI, and he just gave a talk earlier today in the conference about this very particular issue. So, Dr. Thương, can you share with us your experience about the WHI at that time, and what is the current situations of HRT use in Vietnam at the moment, Dr. Thương? Hello. I don't know why he cannot hear us. Yeah, anyway, I don't know why he cannot hear us this time, or he's dropped off the line, I'm not sure. Yeah.
Hello,
Hello. Yes.
I mean, did you get mistake? Did you miss between Dr. Bùi Chí Thương? I am just the same name, but I'm not him.
No, I know.
Sorry. I think you get.
No, I text. He was listening earlier with us, so yeah. So yeah, don't worry. I think he's get dropped off by some reason. Yeah, it's okay. If he's back, then we talk more about that. So, so Hương, you have another case that you want to discuss about the decision to use.
Yeah, yes. Thanks so much for thanks Dr. Fu for sharing us valuable insights into the WHI research. And with this next case, I also want to discuss more in depth about like balancing between the risk and the harm. So as what our team draw from the systematic review of this guideline, what we see from the data is that for type 2 diabetes and osteoporotic fracture, they have evidence of a productive effect of hormone replacement therapy for those menopausal women. So that's the only two diseases that the hormone seems to reduce the risk of developing such disease in the future. So here I would like to summarize for you a case just for this discussion. So it's a 50 years old obese female patient who see you on a regular checkup, complaining of no symptoms of menopause. She has been menopausal for 1 year up to now and is currently on no medications. She is a heavy smoker, and otherwise her past medical history is insignificant. So the patient is asking you whether the HRI benefits her young looking and help prevent some scary disease like colon cancer or bone aging, as she read on the internet. So if you're a doctor, so will you conduct them on using HRI? So when I write up this context, I think for myself that apart from many prompts that we have already seen evidence for developing cardiovascular disease and all kind of those diseases. So if but beside that, the FDA also approved for the use of hormone therapy as the primary prevention for osteoporotic fracture. So I just wondering if in such a cases when you see a patient with high risk for osteoporosis, will you want to conduct them on using HRI, especially if the patient express a concern about this, about developing such a disease? So what would you like? What would you guys think, my fellow?
Okay,
Like,
anyone have any?
do you want to say like this? What are your opinions?
Okay. Yeah. While people are waiting for to form their thoughts and see if anyone can give the opinion, just about the presentations. Sometimes it's also the good idea to capture the attentions of the audience by putting the case like this, or maybe the real case in your experience up here. Like, I had the patients like this with these conditions and come for asking for advice on certain controversial decisions. Then yeah, it's really helpful to put such a case like that. So point out, here is the issue, like this patient, she had this problem, that problems. She is a smoker, like the risk is high, but she was wondering about the use of this treatment, which is also have some benefit, but also carry risk. So yeah, controversial cases like that will help spark the curiosity and, hey, what I'm doing right now, is there anything to back me up? Any evidence of what I'm doing is right? Anything that recently come out that have sway my decisions? So yeah, this is a good case to put out, so that people will have to keep review, go back and look at the literatures, because medicine is keep evolving. What we were taught in med school may not be applied anymore. So yeah, that's just a case will be good. So anyone in the audience would like to give your opinions about these questions? What first? Let's not say whether you're gonna treat the patient or not, but what would you like to tell the patient first? Anyone? Let me call some name then. Let's call someone in our group here first. Jerry Linbo. You still here and listening, Jerry? You're the seniors in the group right now, so just give your personal opinion about these conditions. Jerry, she disappeared. Yeah, Jerry, what would you say if someone approaching you asking about your opinion?
So if a patient approached me to ask me about whether she can use hormone replacement therapy to be more beautiful or younger, I think the best idea is I will advise her to come to see 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 a professional, like Dr. mm, like Dr. Quang Phu Ho.
Okay. You're gonna be the doctor later this year, right, Jerry?
Yeah.
Okay.
But
And this
I
is.
don't have many experience in using hormone replacement therapy. But
Okay.
after this presentation, I can inform her that using estrogen hasn't been proved to improve beauty, but it has been proved to be associated with many risks, including cardiovascular risk, urogenital risk. So I personally don't recommend her to use hormone replacement therapy. Instead, I will advise her to have a healthier lifestyle.
Okay.
Before using any medicine.
Okay. Yeah. So this is not actually it's not a case for specialists. We don't refer patient to specialists for this kind of question. So you got to prepare to answer this kind of question when you become a doctor. And yeah, just like the recommendations of the task force is for primary prevention. So this is the job of the general practitioner, of the internist, to a primary care doctor, to recommend patients. So you should be ready for that.
Yes, I see.
Okay. So let me see if anyone in our audience can help explore a little bit more about this. Thương Nguyễn, you want to answer some questions? Okay. Okay. So this case, we come back about this case. So it's not any particular patients, but the one she's here with some risk of diabetes type 2 and osteoporotic fractures. Yeah, she had her whole family of have like hip fractures. She had the whole family of diabetes. Her sugar is a bit almost borderline or early diabetes already. So she's obese. On the risk factor is there. What would you tell her about what's your idea about this condition, given what we've been talking so far?
Yeah, okay, thank you, Dr. Minh. In this case, I see her gets many risk factors of diabetes and osteoporosis fracture. And I think compare between the advantage and disadvantage of when she used HIT, because FBC HIT can reduce some can prevent the diabetes and osteoporosis fracture in this article. So in my opinion, I think I can advise her use this, because compare between the disadvantage and advantage, and maybe this will help her prevent to disease, we can see she has a high risk factor. Yeah.
Okay, but what will you tell the patient if she's turn around and have a stroke and come back and show you you didn't tell me about the harm of the HRT? What
Yeah.
would you tell her?
Yeah, I know. Okay. It's hard to give the advice because I'm not a specialist. Just I think from the side of the patient. Yeah. Something is not happen in the future. So okay, let me consider about this.
Okay.
Okay.
Okay. Yeah. So that's the beauty of medicines. We don't have the black and white. We don't have the yes and no answers for everything. So that's why the good way is discuss with the patients and help them form informed decisions. Of course, something really dangerous, then definitely you won't prescribe for the patient for any reason. But situation like this, we can consider. Just like Dr. Wapuho said earlier, the benefit of osteoporosis treatments take a long while. It's 5 years, 10 years down the line. But for example, the risk of thromboembolisms is happen when you're on the hormonal therapy. So yes, you need to really tell patient about that. And diabetes, there are many better, safer way to handle the situations. And lifestyle is definitely something we recommend people to do. So whether we go to a little bit risky route rather than pick something a bit safer or not is something we need to discuss. But yeah, the evidence is still out there. It's keep updating. So that's keep us on our toes to be ready to explain to the patient, because Dr. Google is out there. There's no way to take him away. So yeah, patient will come, and patient do come with a lot of information print out, and we need to really sit down and discuss with them about that. So be ready for that.
In case when I hear your opinion, I just wondering if the patient they ask you like, yeah, doctor, I have heard that there's an increased risk of some 5 from 6 disease when I use a hormone, but just to reduce the risk for osteoporosis and diabetes. So it's kind of it's just 2 against 5 or 6. So and out of them it's just the risk. So it haven't happened yet. So if I was the patient, then I might don't feel like I will benefit from a very ambiguous therapy like that. So how do you think?
Okay, I'm not sure I understand the question correctly. So the patient worry about the risk of the using the hormonal therapies, or the patients want to have the benefit of the hormonal therapy?
Like because Dr. Thu has said that the patient they has several risk factors for osteoporosis, so maybe she will consider consult them on using hormone to prevent the disease. But maybe if I was the patient, I will wondering like there's just 2 disease that the hormone have the protective effect, which is diabetes and osteoporosis. But if I use the hormone, then I will vulnerable to developing 5 or 6 other diseases like cardiovascular, breast cancer, urinary incontinence, and some kind of that. So it's like it's not a balance. So like I'm exposed to more risk of more disease than just the two improved risk of diabetes and osteoporosis. It's like an imbalance. So if I was
can I cut short this one? I found it just, I'm sorry, quite annoying with the doctor in Vietnam. I'm sorry, why we keep jump straight into giving patient medication? That's not incident. First of all, there are risk for patient are obese, patient got smoking. We have to correct these problems first and looking global picture first rather than just go straight in treatment. Now, the patient will have advice about lifestyle. Dr. Mendo has said, you have to advise them dietary, not just only dietary, to give them advice, show them how to get a dietary, send up the dietitian. This, I think, probably from our country, but not Vietnam. But you have to keep in mind the medicine in Vietnam will evolve in very quick time. All these things will become reality in the, I think, probably in 5-10 years time. Dietary change. They have to change the diet. They have to improve exercise. And to have to advise the patient about cut down or stop smoking altogether. And they have to give a patient quit smoking advice, how to quit smoking. Need to give them nicotine patches to stop smoking. Because she had a strong family of osteoporotic cancer, the osteoporotic fractures. She needs to take calcium, you need exercise, you need to make the vitamin D. They are the primary the prevention. You don't have to refer to professor. Professor wouldn't do much better than job. Your job, but they charge you 5 times more expensive. The patient think our professor better, but you are the first line. You have to treat the patient in primary care here. And after that, then you talk to the patient. This whole thing tonight, Dr. Bindo showed that the evidence there in front of you, the evidence. The patient they have no symptoms. So you tell, if the most recommendation from the college, from task force, treatment using for treatment menopausal symptom only, because consider risk versus benefit of the weight, risk versus benefit, outweigh the benefit, the risk too high. So even though that the intermittent people taking combined estrogen progesterone, the risk of fractures is decreasing, the risk of diabetic decreasing, but other far too high. See, consider risk factor. So it's guideline in front of you. Based these days, you just don't worry about too much about guessing, because we have all the guidelines available here. Dr. Min did excellent case. This is evidence from task force, evidence from college, ONG have said that this you're probably better. The risk outweigh the benefit. So that's it. You give a patient that always, certified evidence proving the patient. Then if they give them a considering a talk about it, and if they want more information, come back. But at the primary, we have to think careful about your primary prevention rather than treatment. Pump the patient medication. I really annoy students give a ciprofloxacin for UTI. It's amazing. CT scan for UTI. What audit? We have to go back one step. Think here and scientific world now, based on not the professor. We give you evidence or better advice, but you got ton of evidence in front of you. You have to apply it. Guideline in front of you. That's right. That's all here tonight. You look at it. You look at the article Dr. Mintrans and Mendo sent you. That's all there about what the benefit. So that in the long term will help you in practice medicine when we're more confident. You're not, this is first year, your job, the first year come out medical school, and not professor, not me, but yours. So tonight, take home message, please. Always look at the patient at the whole pictures to try to modify the disease. and try prevent disease before you treat the disease. If you need to treat disease, there are guidelines, there are your evidence-based medicine in front of you. You use it, safe. That's good. Everyone will be happy. Just don't guessing around, moving arm, don't make a patient unhappy. Then no something your patient will be unhappy. But you are the clinician. You provide better treatment like this. What else do you get? What the professor can do better than you? No professor. Professor charges 5 times, and he's too busy. He's not going to do much better than you.
Okay. Yeah. Thanks, and Dr. Van Phu Ho. Yeah, I think I just want to make sure if everybody understand. Again, this is guideline for prevention. Okay, so for people who have no problem at all, then the answer is no. It's not cost benefit. Just say that yeah, down the line, if you may die more if you're on this medicine, because you have no reason to be on that. The net benefit is not there. There's no reason to be feel a little bit better, but you die sooner. Then there's no reason for that. And the doctor not helping people die sooner. This is not the role of the doctor. And over here, Nguyễn Trường posed the questions to everyone.
Hello, Min.
Yes.
Could I speak some? Could I speak?
Yes.
Okay, I just look at Nguyễn Trường question, so I would like. Okay, I'm not an expert in this area anyway, but I just have some common sense, especially when you practice in medicine, because medicine is not black and white, and it's very risky business anyway. But like Dr. Phu say, first one that you have to follow the guideline first. Even that the guidelines could be changed, okay? Because the guidelines about 10 years ago may be different from now, okay? So, but currently you have to follow the guidelines first, and then you have to explain the benefit and the risk to the patient. Then you see that the patient have the right to refuse the treatment. So we, as a physician, we have the right to refuse the prescription too. So you see, there's 2 things that you have to think that which one is most benefit to the patient, but at the same time, if the patient insists that they have to have that, you have the right to refuse if you feel that it's not good for you. Okay, so both sides, it's a 2-way street. It's not only way. You not have to follow what the patient want. Okay, you have to use your judgment to make the decision. Thank you.
Yeah. Thank you, Dr. Trinh.
Yeah, just again, it's down to you, the one who make the final decision to prescribe the medicines or not. So there's 2 things over here. Just we are the doctor. We're the one who went through med school. We're the one who's supposed to have more information or access to more medicines than more reliable source of medicines than our patients. So just think that if someone comes to you and says that I have a headache and I require morphine, will you prescribe that? No, right? Yeah, so it's just the same. It's not that severe or that significant prescribing hormonal therapies to the patients, but sit down, go through the evidence with the patients. Hopefully we have time for that. I know Vietnam's condition is a bit difficult, but then listen through and see through. Sometimes the reasons they present to you may not be the reason they come to ask for that particular things. Maybe she's have something, some social issues. The family has something that she's maybe blaming herself on her age. She's asking for that, hoping for it to recover her use. That's maybe something else to tell the patient if you laid out all the information out there and still seem like they're not getting it, maybe there's something behind that. So yeah, listen to the patient, not just their words, but their concern, and have the patient back if you don't feel that you get it. Refer them to the special, not specialists, but the dietitians. Pay attention to lifestyle. Have more community resources to help the patients, rather than just either say no, go away, or yield to their demand and prescribe the medication. Because if things go wrong, and you have no reason to back your decisions, you're the one at fault. So help the patients, but stay your ground. Don't yield to unreasonable requests, which you know that may give harm to the patients.
Hi.
Okay. Yes.
Thank you so much. It's useful for me.
You're welcome. You've been like pushing around by your patients sometimes?
No. I ask these questions because I just a pharmacist. So this is the situation I face to in the pharmacies. The medication is not the prescribed trust. It's just the supplement trust with the estrogens or progestins. So that is it's difficult for me to convince the customer don't use this. That.
Okay. Yes.
You know, sorry. Yeah. You know, I just give you the trick. So, the best way that you have to, because sometimes number one, you have to let the patient make the decision first, and you are the second. Number two, the best way that you can persuade the patient that you list the risk and the benefit in the neutral way. Never say that, oh, this one is much better or this one is okay. You just list the two sides and let the patient make the decision. That's the best way. Thanks.
Yeah. Thank you so much. Yeah.
Okay.
I love it. Yeah.
Yeah. Yes, it's good that we have the real life experience over here to it's evolving into more about discussion, how to talk about certain conditions that the patient may have their own idea, and our medical community have a different suggestion. So it's nowadays a lot of information going around that you may know that a lot of treatment, a lot of suggestion is non-scientific. So as the primary care doctors, you on the front ground, you have to be in the role of the educator to help the patients get the right decisions. They can come back and do whatever they want to, no one can control that. But our role is give them the good information and help clear any confusions from them and help them make the right decisions. And one more thing is that on the relationship over here between the pharmacist and the provider, the doctor over here, is the mutual relationships. You don't have to follow whatever the doctor prescribed if you know that it's not.
Sorry, Min, your voice is cut off.
I think he's out for some reason, maybe the connection.
Yeah, he knows it now. It's something connect with the connector or something. Okay, sometimes I found this Zoom have the problem. The computer just shut down you, and you have to reboot the computer again. It's very bothersome. Okay, that's good. Now, okay.
I think while we're waiting for Min to fix up computer, I just relationship between pharmacists and doctors in Vietnam are quite different from as you know, in Western country. The pharmacists had a lot of knowledge in this country. The pharmacists the one who have to advise the patient about medicine. They study 5 years long, and they have a lot of, you know, power in terms of, you know, advice. They're not going to argue what doctor given, but have to give the patient information, how to take medication, what the risk, what the benefit of the medicine. They're not just prescribing, you know, straight your medicine like ciprofloxacin to the patient straight away, but they can advise there are other medicine are safer, are cheaper. They can advise them. They have a lot of role to play. They're more like the community, you know, person to help, you know, the patient on, you know, a second line after the doctors. A lot of doctors write a script, basic script, and a pharmacy I'm sorry, I'll be wrong, but and the relationship with commission between doctor and the pharmacist is, you know, there's something that's not black and white in Vietnam. But in here, there's no such commission. There's no commission at all. That's illegal. And the doctor and, you know, the pharmacy follow instruction from the doctor, but have the right to, you know, question why the doctor prescribed the medicine, and where, you know, if the patient pregnant, they give the patient doxycycline. Then the pharmacy will not prescribing because they said this is not safe for the patient. Then the pharmacy will call the doctor, doctor, I have the patient, this is pregnant. You prescribe doxycycline. That's the role of the pharmacists in our country, they do. And the doctor said, oh, I'm sorry, I didn't know she was pregnant. That's amazing. A lot of things they pick up mistake from the doctor because they have a lot of knowledge, they have a lot of power, and a lot of willing to advise a patient how to take medicine. It's very important. So again, while we're waiting for Min, just may remember, it's just medicine, practicing medicine, not black and white. There's a lot of litigation, not a legal issue there. And if you know, equip yourself with the knowledge, with humble, with, you know, working with the patient, advise the patient. I don't want to question someone asked on the group chat there. If the patient keep wanting it, of course the patient have the right, but you give them risk versus benefit. And the trouble is if you don't give it to them now, they can go to the next person, the doctor will give it to them. Okay. So again, you know, the guideline, you use a shorter time, lower dose as possible, give the patient, again, ask her to come back, say 2-3 months, said, again, I'd like to review you again to see what the benefit of the medication have given you. They said, no, I haven't seen anything change. So what? No, you can stop medicine. You prove the patient that medication not going to help you. So that's the way. And if they still argue with you, I just said, okay, I'm sorry. I might get to see one of my friends who's one other doctor. I pick up one other doctor. I refer you to get a second opinion. So they go for second opinion. They will come back down. You're not going to lose a patient. They will come back to you because they know that you treat them well. You don't ignore them. They're there, and you refer to someone else. The other person will not, you know, take patient away from you. But I guarantee you, 90% the patient will come back to you because you care. So that's the take-home message. You have to be, you know, when you practice medicine, it's so important to treat the patient as a person, and you get relationship well. They will come back for you 10, 20 years time. They love you, and then you feel happy at the end of the day. Of course, there will be, you know, down the line someone hate you, but that, you know, you see 100 patients a day. Of course, you got 4 or 5 that really, not angry, not happy with you, but so what? That's life. Medical ethics is do no harm. You don't give it something, as the patient wants it. I know in Vietnam at the moment, so much problem with, the doctor and a patient relationship where doctor, doctor get been beating up by the patient, and the family just demanding, if you don't treat me, I'm going to call this, minister, call all the stuff. That's a lot of stressful for doctor at the moment. I've seen it. It's amazing. I know this one, I know that person, I know this. Every time once I've come back to Vietnam a few times, just don't worry. I know this person, I know the minister, I know, don't worry, I can do it. Everything I know is in the room. Oh no, I'm going to call the manager or the director hospital. They threaten you, all mean that way. But I think a lot of aspiring doctor, and Minh still apply, so I can talk to you. You're aspiring doctor, pharmacist, you are the one the best. You have to, medicine will change in 5-10 year time ahead. It's not going to stay the same for a long time. So you bring all this new information, new thing, that would be great. So we'll change and everyone will be happy. That's the way how to practice medicine. Medicine these days are best evidence. We're not guessing anymore. No guessing. No, a professor told me this, the professor now. Yes, professor, maybe 5-10 20 year time, but you can challenge them. This is best evidence-based medicine these days, all randomized control. We're not guessing anymore. You can't teach. You teach, but you have to base it because medicine changing day by day. You change so much. You don't stay there. You stay, you're gonna lose it. If you don't, tonight if Dr. Mindo didn't present, ask you to present it, you probably never know what WHI, not know, her study or PEPI or, many other study there, so many things there. So these things you have to update all the time to keep this one. But again, whether benefit for you to practice medicine in Vietnam is, I think, a bit sadly, I think probably not. Not really practical term at the moment. I can see very, heart attack when I see, all the patient, doctor, all ciprofloxacin. I just so, I'm sorry, really, I want to swear, but I think it's somehow too much. Something have to change to get it better for the patient rather than get the patient dictate you what to do, and the doctor dictate you, and you heard about all negative thing about doctor taking money, all that make it so medicine become a bit, like sad place for you to work at the moment, I think. But again, you see on Facebook, all the doctor, all professor, you travel overseas, posting all the picture, that's quite fantastic, quite nice. They got kids sent overseas, and they all, sometimes I wonder why, how, if they see every doctor say, in Vietnam doctor are very poor, get paid, like 25,000 dong for, on-call all night. I wonder where's the money, they send the kids overseas, they travel, all that. Something is really not very, a lot of things need to change and make the life of the doctor better. Okay, so I probably about nearly 1 o'clock in Australia now. I just have to say goodbye. I'm glad to see Hương again. Hương used to come here as the medical student. Tuấn, I probably see him tomorrow. Tuyền, I might see her tomorrow. But Jerry, I used to see her in Medic Cafe. I heard, but bottom line is, if you equip with your information like this, you gotta practice medicine as the best doctor. Don't lose it. Get it with your Dr. Minh. And I hope this journal club will go in because it's so vital, important. WHI study, you probably ask you doctor in Vietnam, many doctors in Vietnam, they don't even know what did that study, and what. They know that WHI study, but you ask them a context of what the conclusion is, probably they don't know. They just something is still too busy. Okay, so good. Tuấn, I criticize you in the way you're presenting, but next time you have to give some more depth into it. when you extracting data out of this, that task force needs more data out to prove that, what you're talking about. You see, you can put all slide, like when how many case breast cancer, how many things, that's probably bad. But sometimes you put too big the slide in D, C, D, too much. When you read it, too hard for me to read it. So just summarize and talk, like less wording in that one will be better. Okay, good night, everyone. Good night, Vân. See you tomorrow. Good night, everybody. So hope you enjoy it. Okay, bye.
Okay, thanks and Phúc.
Bye. Bye.
Good night, Dr. Phu.
Bye bye.
Okay, now I think that Dr. Min just on and off the screen all the time. I'm not sure what's the problem with his technical difficulties, but anyway, I think that is enough for us to stop the meeting. I'm just waiting. Oh no, today. But first, I would like to say something to you. It's a good idea that you have very controversial issues, so you think more. It's nothing carved in stone. Okay, it's very flexible. What you think right today may be different tomorrow. So that's why we keep learning all the time. So now waiting for Min go back. I'm not sure, maybe we cut it off, but I just by my time, I just think about being a doctor or pharmacist in Vietnam is more challenge than here, okay? Because you have a lot of pressure. The doctors describe or not describe, the pharmacist has to sell something that, over the counter or even that's undescribed one. So you have too many pressure to you, okay? Because if you do the correct way, okay, somebody will find something to do illegally. So that's a tough one. I think that the system have to be revamped in total rather than by individual. So that's why it's hard for you. I understand about that. Okay.
Hello.
Hi, Min.
Yeah, I'm sorry. There's some technical issue. I got kicked out for some reason. I don't know. Now I use my phone right now, so let me see. I can show my face again.
Sometimes usually that somebody log in with our
with the host account.
Could be Win. Okay, he asked out many times because he just get in with the log in with the ID. So so you as a host, you be kicked out.
We get to have some kind of like sign sheet to make sure we don't kick people out. So I'm not sure what you were talking about. Why am
Dr. Phu just left. Okay, so I think we just waiting for you. But anyway, so far that's good. So far, you have something to tell us, or somebody here have some idea to tell us before we can stop it. Okay.
Yeah, I think we did have a good discussions today, not just about the article itself, but also touching a little bit about the relationships between doctors and patients, as well as between doctor and pharmacists, and and of course the doctor together. We on the same side, but it doesn't mean that the patient on the opposite side, provider on this side, patient on the opposite side. No, we don't take sides like that. They are not our enemies. We take care of each other. But I understand it's difficult in Vietnam situation, time, trust, and that's not always an ideal condition for a provider in Vietnam to really share what we have, what we think to the patient. So it's just no answer for every questions, but hopefully we got to be ourselves, stay professional, but also still care for the patients with the best we have in our hands. There's no guideline for that, no guideline for that. Besides what we try to do the best we could, and again, the take-home message today is stay up to date. I think stay up to date with the information. Get the best knowledge you could, especially in the controversial issue, because it's difficult to convince people. It doesn't mean the doctor's always right. We was wrong before the WHI, but with more information, we know more. We can provide the benefit for the patients. Actually, I chatted with Dr. Thương just a little bit when I'm offline. He's sorry that he could not join us today. He's had a long conference and then go to have operations and things. He's still practicing today, so he just cannot join us. But he does tell us that the situation in Vietnam after the WHI, the use of hormonal therapies really went down more than it's really have to, because of course for prevention is not recommended, but for treatment the patient should not bear all the side effect, should not stay away from the benefit of the treatment if they need to. So WHI really scare patients away from that, unnecessarily scare patients away from that. So as the role of the provider, let patient know what is the latest information, what the benefit that they may have, of course, what the risk may come with the treatment, and have the patient make the decision. Anything we do carry risk, anything, not just prescribing medication. If you go out to work every day, that you carry the risk of getting to accident. So anything we do carry risk, but we got to balance, consider the risk and the benefit, and help our patient make the right decisions. Okay, so I give the microphone back to the presenter today, Hương Trần, Tuấn Trần, and what's your name? Oh, she's gone already. Yoon, she's not here anymore. Yes. So any feedback from? Oh, actually, there's some spelling that I may want to correct. I need to go back to the list to correct a little bit. Like sweat. I think Tuấn Trần made some error about that. Primary, I think Hương Trần, you may spell it a little bit differently. Primary, I think we stress on the first syllable. Just some minor thing, but you did a good job preparing the talk and practice for that. And as Tuấn Trần, I don't have a lot of time to review the whole slide with you, so I just help with the pronunciations. But then, keep practicing. It's a chance for you to do that. So. That's my feedback for today. Any last word from the presenting team before we end our journal club today?
I think that I would just like to, we prepare a take-home message for the last slide. So now maybe I will do it right now. So to wrap up the topic, so the take-home message will be from the guideline that they don't advise the use of hormone therapy for the primary prevention of chronic condition in postmenopausal women of average risk. So this means that for the population or the women who have some kind of risk other than the average population, so this guideline doesn't apply to them, then in that case, so the patient will benefit from the shared and individualized clinical nutrition. So I think that that will be the key thing to keep in mind. I would like to thank Dr. Minh Do and Dr. Đinh Nguyễn and everyone here for staying with us until now, and especially Dr. Mindo, you helped us very much in preparing the presentation. I personally really appreciate when you send us the summary from Dr. Fu, which saved me a lot of time, and it encouraged me to read more because I'm too lazy. So thanks so much for going with us like this. So thank everyone for attending with us. So hope to see you in the next session.
Okay, yeah. Afternoon,
okay. We can stop here, huh? Okay. I'm so hungry now.
Yeah, especially thanks Dr. Đinh Nguyễn. He have the marathon webinar yesterday, today, and later today also. So Tuấn Trần and those who with the webinar tomorrow, be prepared. Tuấn Trần, especially Tuấn Trần, be prepared. Okay.
Okay. Bye bye.
Bye. Have a good weekend.